You're good. Just let me.
Okay,
I'll
perfect.
try.
Excellent.
All right. We have ladies coming in the room right now, participants, attendees that signed up. And so we'll just kind of keep that going.
Okay, well, welcome everybody. I'm just gonna do a little pitter patter as we're letting people come in the room. You missed this really vibrant conversation between Dr. Uloko and I around our glasses. And I let her know that she is my icon for eyeglass accessories, and that these glasses that I'm now wearing were well because of her. And just, you know, as you get to know Dr. Uloko and you watch her on Instagram or you go to see her, you'll notice that she's got a strong eyeglass game going on. So who is Dr. Uloko? Who is Pamela Madsen? What are we doing here? So when I met Dr. Uloko, it was almost 2 years ago now, I think.
Yeah.
2.5,
Yes, it
yeah.
was. Yeah.
And one of our clients that we both share, a patient for you and a client for me, wanted Dr. Uloko to come to one of our portals to see what this was all about. And she was a brave soul and she came right in there. And that's when I met her. And I'm going to tell you why I fell in love with her. It wasn't her glasses, though they were really good then. They were really good. The black and white ones, super cool. Um, it was that she had the brain, the brain to question this notion of how many nerve endings does a woman have in her clitoris? And you know, we all knew it was 8,000, and all of us sex educators were bragging about our 8,000 nerve endings. And Dr. Uloko said, Pamela, that's a cow. And I was like, what? She said they studied a cow. That's a cow clitoris. And I couldn't believe that we had all just accepted that. And it took Dr. Uloko to say, excuse me, this is not a human clitoris. You are studying a bovine and passing it off to women as their clit. And it was actually, you know, it kind of said everything that there is to say about the perspective and the importance of female anatomy. And what did you find out, Dr. Uloko?
And we have way more nerves than 8,000. The nerves that we can actually quantify was over 10,000. And that is just one specific type of nerve. Then when we really think down to it, we have three different types of innervations to the clitoris. And the current technology that we have can only quantify one type. So looking at that, we quantified that we had over 10,000 nerves, which is more than in the hand, which is considered one of the most innervated structures in the body so far. So the clitoris has way more nerves than the human hand, which has a crazy amount of nerves. So it's just it's another story of how miraculous the human body is and how miraculous the clitoris is. Because
And how we need female doctors
yes,
actually know
yes,
this and ask questions about female bodies. And
yeah,
so if
yes.
you are in the right place, everybody. If you want to know all the things, we can't do all the things, but a lot of the things about vulva health. And I hope that we get your questions answered and bring up things that you may feel shame about or you may be noticing in your body and haven't spoken to anyone about. Dr. Maria Uloko is someone who's also available to you guys, and we'll share all that information at the end.
So they can put their questions in the chat box, or they
Thank you,
can put it privately in the question box. Just privately even message me, and I'll be monitoring all the questions, and we'll throw them back to Pamela and Dr. Uloko at the end, and they can answer as many as they can get to. And
Thank
then
you.
I'm gonna say, I'll see you towards the end of the webinar. I'll be here for you as you need me.
But she's monitoring all the chats, so she's
Yep.
with us, because I'd be frightened if she left. So, just, as a disclaimer and in truth, this is not to replace medical advice from your doctor. It's meant to have you go straight to your doctor and to your PCP and ask the right questions and advocate for your sexual wellness and be informed about what we know about vulvar health. And of course, you can, we'll tell you about how you could actually work with Dr. Uloko. I really would like you to be my vulva doctor. Thank you very much. I'm moving to California and I want you. Only you.
Oh,
Only you between my legs, honey. Only you. So
my honor and my pleasure.
And who am I? I'm Pamela Madsen. For those of you who don't know me, I'm the founder and you can read the slide. I'm the founder and CEO of Sensuous Back to the Body, Sensuous Retreats for Women. And I teach women about pleasure and sexual wellness. And my book is called Shameless. And I think what's important to know about me is that I come from a very academic background. And I founded the American Fertility Association. A lot of what you know about biological clock is through a study I did with Dr. Richard Scott. And we found out that women thought that their fertility declined at around 42. Well, they were a little off. Fertility begins to decline at 27. And then we developed a conversation around biological clock and what that means. And that's what got me on Oprah and all the things. So I believe in data, I believe in science. And I love that Dr. Uloko is open to this world, because we need medical professionals who are data-driven and heart-driven to take care of women. So she's a urologist and a comprehensive sexual medicine specialist. And I love this thing that she's developed called Menopause Boot Camp. Very, very cool. You'll tell us about that. And MUMD, focusing on sexual dysfunction via telehealth. And yes, she's the one, 10,000 nerve endings. I did that. I gave that away. And she won in 2022 Best Female Sexual Medicine Award and Best Basic Science Award. You are my lady. Welcome, Dr. Maria Uloko, to this beautiful presentation.
Thank you for having me.
It's exciting because this came out of a conversation that Dr. Uloko and I had, which is that nobody is really teaching about sexual health over the lifespan. Mostly we frighten women.
Yes.
Can you talk about some of the ways that we frighten women?
Yeah, it's one of the things that I've found very fascinating. I've been in healthcare. Hello, everyone. My name is Dr. Maria Uloko. I'm so happy that you all are here and here to learn all about your vulva, because these are things that you will not find in the common anywhere, really, which is the problem. And so I've been in medicine since I was 17 years old. I started med school at 17.
Oh my God.
Been 15 years of being in healthcare. And it wasn't until I did my fellowship in sexual health, comprehensive sexual health, which is taking care of the sexual health of all genders, all sexes, which is the only fellowship program in the country, did I actually start learning about women's bodies, which is crazy. This was 2020 and I'd already been in healthcare for like 10 years and I still had never learned about women's bodies and people with vulvas. And, I am a urologist. We are in the vulva all the time and yet we are not taught. And this is the crazy thing. Many gynecologists are also not taught. In medicine, there's this really, there's this notion that as people age, particularly women, they just suffer and that's okay. Versus men, it's a fun thing to like to be able to, my superpower is being able to treat everyone. And because of that, I get to also compare how people are treated in the healthcare system. With men, as they age, there's so much support. And there's also this understanding that, you know, men should always have erections and they should always have good sex lives, no matter till their last day on earth. And their penises should always be healthy and functioning. And then in women, the idea is that, yeah, they just develop UTIs, they just stop having sex, they just start having painful sex. That's okay. It's not saying that it's not normal. All of this is normal. Men get erectile dysfunction, that's normal. Women get vulvar dysfunction and painful sex and dryness and changes in their vulva, that's also normal, but it's not accepted in men, but we accept it in women. And so one thing I want people to know about their vulva is that it's constantly changing. It is so sensitive to hormones, constantly changing. With perimenopause, you get a rapid change in a decline in the health of your vulva without appropriate hormones. And also the thing I want you to know is that the vulva is like, truly as a researcher, I think the secret of life is in the vulva. Because if you give the vulva exactly what it needs, it's able to heal itself. It's able to regenerate and become healthy. I'm a big believer, in a perfect world, you should have the same vulva in your teens as you do at 100 years old. There is no reason that we are allowing people to have unhealthy vulvas outside of just kind of medical neglect and our society's acceptance of women and suffering and their lack of sexual agency and health.
Absolutely. And I wanted to say before we talk more about, because there's already questions or questions about things we've talked about already before we got on. Is that unless I'm a unicorn, and I don't think I am, because I work with lots of women over 40, over 50, over 60, over 70, over 80, and my mother at 93. Okay. That for me, except for some of these little tweaky things, a little pain sometimes in my lower introitus, I mentioned that to you. My sexuality has grown. My ability to have orgasm when I was 21, I was one and done. And I am 60, I'm saying it now. I am 60.
Yes, own it.
And I have 15 or 16 orgasms. And
love that.
My pussy, my favorite story was with a lover, and after a whole like lovely time, and he was much younger than me, comes into our bedroom and he's eating a pork chop. And we have an age gap. And I said to him, "Why are you eating a pork chop?" And it was late. He goes, "Well, honey, I didn't expect to run a 5K. And so know that over 50, over 60, over 70, it doesn't have to be just dysfunction. Am I a unicorn, or is this possible for all women?
So I'm a big believer that this is aspirational and possible, right? And it's challenging that acceptance that as you age, you just lose your sexuality. That's not the case. And I think because society has said, oh, women, they don't like to have sex, like especially outside of, having children, that I love that. I love those stories. And I wish more people had those stories. And I wish more of those stories were told and said out loud, because I think it gives permission to other women, other people with vulvas, to own their sexuality, to have higher standards for themselves, to say, no, I want to be doing this if I want to be doing this for the rest of my life. And I want to be healthy. And also, like, not just sex. So sex is amazing and pleasurable and fun, but there's also diseases that can also come from poor vulvar health, like urinary tract infections, chronic pain, vaginal infections. If you don't have a healthy vulva, it actually sets you up for other diseases. So there's kind of this, we want to live a life absent of disease and also full of pleasure. And that is the goal that I want for everyone.
I love that. I'm going to put this one other antidote and we'll dive in. The antidote, those who like know me and watch me, I brought my 93-year-old mother to a back to the body retreat. She hadn't had sex or touch for 40 years.
Oh.
her body remembered.
Yes.
She was orgasmic. She was ejaculating. And, she talked about that women are fed a lie. Women are fed a lie that they don't need this and that this goes away and that after menopause it disappears. And she was like, and I'm back. And at 93, after 40 years, and I've seen this over and over and over again at my programs, women who think they don't have libido, really what they have is boredom. They have sexual boredom. So I look at a lot of vulvas in my work. I see a lot of vulva. And one of the common things, and we have questions here, Dr. Uloko, but we'll just start with this one. And then we'll go into these questions that are up here. One of the most common things, there's two common things. One of them is the top question. One of the common things I notice about women's vulvas as they age, and I'm not talking ancient vulvas here, okay? I'm talking about women in their 40s, 50s, and 60s. And they notice, and I notice, like, you like that? I notice that their inner labia, and does everyone know what an inner labia is? So the lips outside is your outer labia, that's where the hair is. And then those little parts on the inside that look a little bit like a rooster's coxcomb, those are your inner labias.
That's a good analogy.
You like that?
Yeah, I like that a lot.
And they notice that their body starts to absorb their inner labia, and even their clitoris starts to absorb. What causes that? Is that alarming? Can we fix that? What is that about? Because it can be scary that you're a disappearing pussy.
Yeah, yes. So this is like my whole, if my legacy in life is that I taught people with vulvas and women that their anatomy changes through their life, that there's all these silent changes happening between your legs that you are not aware of until it starts becoming UTIs, sexual dysfunction, pain, I will die happy. That is the one thing I want to teach. So because I take care of penises and vulvas, I want to give an analogy. If I were to tell you that the penis, once it got to perimenopause and menopause, and essentially states where our hormones are naturally declining, because menopause is a very natural part of life, that should be celebrated and not be afraid of. But what if I told you that because of that lack of hormones, the penis now starts shrinking, shriveling, becoming red, raw, infected, prone to infections, prone to pain, does not, lubricate as well as it used to? Everyone would know about this. This would be in every single the sports events, commercials, all the things. There'd be PSAs everywhere. That doesn't happen to men, but that is what is happening to every single person with a vulva. Their vulvas are very hormonally sensitive. I use the analogy of a garden, which I'm so sorry, everyone. It's such a it's too on the nose.
It works.
Yeah. But at the same time, when we think about the vulva is a garden. I just always start this with my patients. So your vulva is a garden and it needs sunlight, water, nutrients. Very much like your vulva needs hormones. It needs hormones, period. So when you go through puberty, your vulva actually elongates, your labia elongates, your clitoris enlarges, your glands start to secrete. All of these things that make you ready for sexual maturation and ready to have sex, those things happen. And then as your body starts to decline in terms of hormone status, perimenopause, menopause, your vulva actually starts to change, and it actually reverts back to when you were a baby. And so as a urologist, when I was in residency, we would get called so many times emergently to the bedside for a woman whose vulva was this big, and they couldn't find her urethra. Y'all, that should have never happened. It wasn't until my fellowship and my research and I started doing this work where I realized all of those changes that we accept in healthcare are actually very preventable. So in a perfect world, my dream world is that when you're getting your mammograms, when you're getting your colonoscopies, your doctor is also doing a vulvar health screen and making sure that you're on the appropriate hormones. So when your hormones naturally stop producing, there are also low dose vaginal hormones that can help prevent these changes from happening. They can prevent you from having UTIs. They can prevent you from having pain with sex. They can prevent you from having chronic vaginal infections. They can prevent all these physical changes that you've noticed and I see it all the time. But because our healthcare system doesn't value women's sexuality, it doesn't value women outside of reproduction, we just let these things happen. And then so these patients come to me and everything is small and tight and painful and awful and they're suffering. And then I give them some low dose vaginal hormones though. And this is the beauty and the magic of the vulva. And then it starts opening back up and the tissue starts healing and your microbiome gets back to normal. And this is why I use that garden analogy, because even if your garden this year doesn't make cucumbers or you don't get it doesn't look like it's doing well, you just give it some love, you give it some nutrients, you give it some low dose vaginal hormones, and it's right back to where it started.
So
Labial.
I'm sorry, continue.
The labia though, the labial length though is harder to get back. You know, like if you want your vulva to look like it did in the 20s, that's why you should start early. We can't potentially get that full cosmesis and all like it used to look in the 20s if we start it, 20 years after menopause, but can we get it back to healthy 100%?
I love this, and I love what you said, because this is what actually started our conversation around this, was a vulva health check. And what I had shared with Dr. Maria was that, I mean, I'm now this like big confession here, right? I used to go every year to the gynecologist. And I would get my pap smear and this and that and the other thing done, right? And then after menopause, I stopped going. I think it's been 3 years since I've gone, because no one is saying to me, they're telling me to get my mammogram, but no one is reminding women over 40 or women over 50 or over 60, you need to go to the gynecologist and you need to take care of your garden, and that there are things that you can do so you don't end up, and I'm feeling like really I feel a sense of urgency around my vulva right now. Okay, I'm not doing these things that you're talking about, and I'm very invested in my vulva and in the pleasure and the health of my body. And so why don't we take this first question, Maria, because I talked about this right in the beginning. Because a lot of I see at Back to the Body occasionally women who have lichen, I'm not going to say it correctly.
Lichen sclerosus.
Yes. And it's painful and frustrating for women.
Mm-hmm.
And I see it. It's not all the time, but it's not uncommon. And I only learned about it by seeing it in my clients, and my clients having questions about it. And we see about 100 women a year. That's our capacity.
Mm-hmm.
I see it about twice a year.
Yeah. Yeah, it's very common. It's one of those, again, if we actually as a medical community cared about the vulva. I actually teach I've taught at Harvard, I've taught at Yale, I've taught at UCLA, I'm teaching at USC next week. I've taught at the American Society of Reproductive Medicine, all the REI doctors, the infertility doctors. I teach them about the vulva. Yeah, I teach them about the vulva, and I always challenge them too and saying like, hey, you all are gynecologists. Why aren't you learning about these things? Why aren't we learning and prioritizing vulvar health? They learn a lot about the internal structures, the uterus, the cervix. They learn all of those things, but their training actually isn't teaching them about the vulva and how to keep the vulva healthy. And so, one of the things I see often is lichen sclerosus. So I say that at my job, unfortunately, I'm oftentimes the second, third, fourth, 16th opinion for these women. And they're coming to me with all these complaints. And they're like, but I've been told I'm normal. And I was like, well, let's just do an exam and see what's going on. every time I find something and I'm like, how have you just been allowed to live life like this? Like, you're not crazy. This is what's going on. This is a disease state, and this is also preventable and reversible. So lichen sclerosus is a inflammatory, it's an autoimmune disorder. It's your body is essentially attacking your system. We see it on mucosal surfaces, so we can see lichen-esque changes in the mouth, and we also see it in the vulva. So what's happening is that your genital tissue is literally scarring down. And so that can cause pain with sex, that can cause lack of pleasure, because it can also scar down and fuse over the clitoris, all of these things. The thing is, we see this in two modal distributions, meaning like we see it when you're a baby. We see this a lot in like prepubescent, pre-hormone kids. And we also see it in post-menopausal people. What's the same thing? All without hormones. That's what happens to the tissue when we don't have hormones for certain people. The thing is, lichen sclerosus is very, very treatable. What you do in a perfect world, if we were to be, I would love this study. This is the other thing. There's just so little people caring about this work that there's not even a lot of robust research around this. But I would assume, just looking at the history, like the science behind lichen, we see this in estrogen deficient states. Menopause is in estrogen deficient states. That's when we see a big rise in it. In a perfect world, if we would be starting vaginal hormones at that appropriate time before these changes start happening, how amazing would this be that we could prevent all of this suffering? Because the scarring can also lead to vulvar cancer. So vulvar cancer is one of the most rare cancers with the highest incidence that we see with vulvar cancer in women with lichen sclerosus. So for my lichen patients, when they come to me, I diagnose them. I don't need to take a biopsy, because the other thing, there's a lot of invasive procedures done to women that don't actually change management and actually just put more suffering on them. We start them on a regimen of a topical steroid to help prevent the inflammation, to help reverse the scarring. Sometimes the scarring, though, is so severe that they actually need surgical intervention. I want to prevent that. That's my thing. That's why I practice, and I never will stop talking about vulvar health, because if I can prevent someone from having lichen sclerosus surgery, I've done my job. But these conditions are preventable and also treatable when caught early. And that's the other reason, ladies, people with vulvas, look at your vulva. These changes are happening in between your legs and you have no idea. And yet, when we catch them early, we can treat them better and prevent all of these downstream effects.
So the end of her question was, can the elasticity of the vulva skin be reversed?
It can. When we do when it all depends. If it's early and we are doing vaginal hormones, low dose vaginal hormones plus the steroids to prevent the inflammation, 100%. We can get your vulva back to healthy. The longer that you wait, though, the lack of awareness around your vulva, the lack of awareness around these disease states does make it harder to reverse the scarring that has happened and makes it harder to get back the elasticity. But if we can catch these things early, we can prevent and reverse a lot of what we see.
So thank you. I'm seeing a lot of questions around complex cystitis symptoms, chronic cystitis.
That's my favorite.
And if you can, are you able to open and actually read the questions?
Yeah, let's see.
Because I worry about mispronouncing medical terms.
Yeah.
And so I'm looking at question number 2 and question number 3. And they're asking about cystitis and how they manage that and how they wade through the medical system. Yes. You see questions 2 and 3?
Yes. Okay, so I always tell people a healthy vulva is a healthy bladder. There are prioritizing your vulvar health. And again, this is one of the tricky things, because there's just not enough doctors that are vulvar specialists that have actually taken the time to understand the science behind the vulva and how to keep it healthy. And again, because medicine doesn't value women's sexuality. And because we assume that the vulva is just about sex, we forget that there's a lot of health related to it, like your bladder health. So many people with conditions like recurrent UTIs and IC, we actually did a study in my clinic looking at people coming in with recurrent UTIs. And they were essentially all my pelvic pain patients. And a lot of my pelvic pain patients have hormonal issues, and their hormonal issues are what cause their pain. So I was like, wait a second, all of these patients have very similar symptoms and very similar presentations. Let me do a study. So I did a study where I essentially did the AUA guidelines plus my specific vulvar protocol. And I found that 65% of postmenopausal women with recurrent UTIs, they had self-diagnosed or been diagnosed with, urgency, frequency, essentially cystitis, over and over and over again, sometimes with positive cultures, sometimes with negative cultures, but just chronically suffering. They actually, 65% actually had a vulvar condition, an inflammatory hormonal vulvar condition. We treated their vulva, we completely stopped their UTIs. One of my absolute favorite patients and stories where I really saw that just like it changed me fundamentally as a physician was a 90-something-year-old woman who was in the emergency room, urgent care every week. Her just burning symptoms, just miserable, just trying to find care. She finally found me, and I evaluated her, did my workup, put her in this protocol. She now has not had UTIs for years, and so many of my patients are this way. Even in our healthcare system, we are misdiagnosing so much of this disease because we're not taught about the vulva. We get really deep into the weeds of the bladder, but actually one part of the vulva is actually bladder tissue on the outside of the body. And that bladder tissue, it's called the vestibule, and it's actually really testosterone sensitive tissue. Without testosterone, this tissue becomes red, raw, and inflamed, and it also mimics the symptoms of UTIs. It also mimics the symptoms of interstitial cystitis. It also then changes your normal bacteria so that the healthy bacteria isn't there to protect you. Estrogen is a very important part of this, but people keep forgetting about testosterone, and that is like where my research baby is also truly just doing science instead of dogma. We know that women make estrogen. That's the thing, but actually your ovaries are producing about 10 times more testosterone, 10 to 100 times more testosterone, depending on where you're at in your cycle, than estrogen at any given time. Testosterone is a dominant, it's everyone makes this hormones, but because medicine is so behind when it comes to women's health, we're just giving you vaginal estrogen, or we're just talking to you about estrogen, and we're not actually treating you like a whole person. And so we're missing a lot of disease. I'm a big believer in this. Yeah.
So I've been offered a testosterone like bullet like in my butt. They pop it in your butt. So you think that that's as important as the estrogen as we age is to add testosterone? Am I hearing that correctly?
You're 100% correct in terms of testosterone. So the pellets, I do, this is where it gets a little tricky, right? So I think about it like recipes. Let's make this as simple as possible. We're just going to break this down into recipes. To make a healthy vulva, you need estrogen and testosterone, period. So that's it.
And a little love.
Yeah, and a little love, right? And the thing is, healthcare currently is only talking to us about half of that recipe. And most people, they're not even getting that conversation. So everyone should be on, when you're perimenopausal, menopausal, I'm a big believer that you should be on some sort of low dose vaginal hormone. The widely accepted one, if your doctor is even doing their due diligence, is vaginal estrogen. Again, vaginal estrogen is amazing. I'm not saying anything. I'm just saying it's, for most people, it's only half of the recipe. You also need that testosterone piece. And there's only, unfortunately, this is where science and policy and insurance and medications really lag behind, because there's only one medication on the market that is vaginal DHEA, which is then turns into estrogen and testosterone. That's the only option on the market so far. But that's if and if I were to be going through, I'm not perimenopausal yet, but as soon as I am, I'm putting in I'm doing estrogen and testosterone. I'm not, I just
So you're
am a big
you're not
believer.
a pellet fan though. I'm hearing that.
Yeah, well, again, the pellet is, and I think it speaks to the larger idea that unfortunately, science hasn't caught up with, science and healthcare have not caught up with what's actually happening, right? So there's still not an FDA approved option for testosterone for women. Even though the science shows that women need testosterone, even though there are many guidelines on testosterone administration for women, I've written one of them. I got to write one of these papers.
Wow.
There's still not an option. What happens is that women then have to use the male dose and then divide and then like essentially divide it and use the male dose and divide it. So the pellet is filling that equation, but it's oftentimes too big of a dose for most people. So that's the only reason I don't like it. And there's just not enough research around it. And also, I know that it has so much benefit. It could potentially have so much benefit. We just need a lot more research around it. I think it just speaks to the greater idea that there's just not great resources for women that want to pursue their sexual health.
I got really randy on it and my clitoris grew 3 sizes.
Yeah, that's it's just like such a big dose of testosterone, and because what we want to do is just get you back to your body's normal level.
I gotta be honest, I kind of liked it.
I mean, listen, I've been on testosterone. I think it's fun, but at the same time, not everyone wants that, and so my job is to try to just get you back to your body's normal. And so that's why I don't strongly recommend the pellet for everyone. It's just too much for a lot of people, and we still don't know the health and the safety side effects yet, just because no one's really doing this research. That's what I spend a lot of my time trying to add to this body of research so that we can answer these questions, so that we can start offering things to patients. But it's a slow process, and at this point in time, I can't safely say go out and put it in a pellet. But I would at least say there are options that are safer than the pellet first.
Thank you. So we have somebody who's pining for you, who says, I'm going through hell since you left UCSD. The doctor telling me I'm 10 years after menopause and should be on the patch now. I'm using progesterone, and I'm using progesterone the wrong way. Who do I trust?
Yeah, so this is the unfortunate thing, is that many doctors, I think the stat is that less than like 10% of doctors are not trained in menopause. So that's what you're going up against. You're going up against 90% of the healthcare field that doesn't actually know the science behind your body. Y'all, I am working hard to like teach these doctors and to get them to care. But it's unfortunate, like this is what's happening, right? That so many women are being told wrong information about their bodies. So the WHI study that came out in 2001 really scared doctors from like learning about hormone replacement therapy and doing this work, and also pushing the envelope. So if we look at the National American Menopause Society guidelines, they say that that the safest time to start hormones is between before the age of 60 or within 10 years of starting menopause. And then they actually have explicit wording of like, if you're still symptomatic, you can have what's called shared decision making, and continue your hormones. The way I trained as a urologist, because again, I come at this very differently than the gynecologist. We don't tell men, oh, at 60, you have to get off of your testosterone.
No,
They could
really,
not, like,
they're pumping it up at 60.
right? Right? Like they would never stop that. Like, oh, okay, 60, you've
So
reached
is that about the cultural thing that we just
Yes.
are not having sex?
Yes, that's what it is. Like it's this like I can't add anything more to that, right? It's just that this is what this is. There's no push. There's no one really pushing for women's quality of life in the research space on these guidelines. They're trying, right? They're trying to just get you by, but there's this, again, this general acceptance in healthcare that like it's okay for women to suffer. It's okay.
Right.
And so many women will get to the age of 60 and they're still having symptoms and their doctors aren't willing to have these conversations with them. They're a little bit more complicated, they're a little bit more challenging, but it's ultimately presenting the facts to the patient and saying, hey, I don't live in your body. You live in your body. I'm going to give you all the risks and the benefits, and you're going to figure out what is the most acceptable thing for you. I will say for myself, the way that I know the science behind this work, I will be on hormones until my very last day on earth, period. I do not want to suffer. Like I don't want to suffer. And I know that I can do, and I do this with so many patients, you can do hormones very safely with constant checking and shared decision making. But I think the general consensus right now is, you know, before the age of 60, within 10 years, and then shared decision making. And this is where I want to empower women to start having these conversations. Like shared decision making means that I have agency. I can make choices about my own body. My doctor gives me the information and I get to make the choice. Do not let your doctor start taking you off things that you desperately need. And you know your body best. Yeah.
I love this. And we're going to answer all your questions. I promise you. I want to insert something in here, into the conversation that we're having. So we have changing and aging bodies. We start aging the minute we're born. Okay. So the one thing that is for sure is that we age, right? And if we're lucky, we age a long, long time. And so I see women who want to get back in the game, want to finally, it's sort of like one of the women have said to me, I've explored the entire world, Rome, Italy, Thailand, all the foods. I've explored everything but my body.
Oh, I love that.
And that's very common with the women that I see. Is they want to go to a journey. They don't want to they don't want they want to use up all that was possible in their erotic selves before they hit their final resting place.
Yes.
Now, if they were sexually inactive, maybe for as long as 30 years. I mean, this is like no joke, right? You get a divorce in your 40s, now you're 50 and it's been 20 years. What can women do? Now, what I'm hearing you say is these microdoses hormones, these vaginal hormones, including testosterone and having vulvar health checks. But what else can we do so that we're game ready when the game is fine? You meet the person or you're really starting to sell pleasure. What can women do to keep their vaginal health? What can we do to keep our canal open?
Yeah. Yes. So hormones will do that. So that's the beauty of it. Like hormones will keep your vulva healthy. It will keep it open, moist,
We
wet,
don't need
tissue
dilators.
supple. No. So all the things that we see on the market are actually just symptoms of poor vulvar health. Dilators definitely help. That I take that back. Dilators are very helpful for tight pelvic floors. If your pelvic floor is really, really, really tight, a dilator is really helpful to help relax that pelvic floor. But in a perfect world, if you have the hormones to that tissue, whoever designed humans, whoever designed the vulva knew what they were doing. If you just give it what it needs, it is made for wear and tear. If you just give it what it needs, it will bounce back. I honestly, like my next research, we're mapping out the vulva, the full vulva now, starting with the clitoris, and we are going down to the vestibule. But one of the most fun things that I've seen as a vulvar specialist, I think the secret of life is in the vulva. I've had women come to me and their vulvas are like scarred down and their vaginas are scarred down and everything just looks, they're so defeated and they're constantly getting UTIs. They're constantly like this, that, and the other. I tell them, give me 6 weeks. Just start with 6 weeks. Start using this every night. This low dose vaginal hormones every night. Come back 6 weeks. And they're so skeptical. My job is oftentimes like having to sell them on an idea that they don't never believe in. at that 6-week visit is one of my favorite visits because they're like, I actually haven't had a UTI. Oh, my tissues are feeling a little better. Da, da, da. And then we do an exam together and they get to see the changes and they are so blown away. And I'm also blown away. Like every day I'm like, whoa, this is the secret of life is in the vulva. I think the secret to eternal youth is in the vulva. There's something in that tissue. The penis does not do this. I cannot figure out, I do regenerative therapies for the penis. We have not yet figured out how to do this. And yet this is the power of the vulva. If you just give it what it needs, it will fix itself.
I'm going to just quote you forever that the secret of life is in the vulva. I mean,
I
what I know,
promise you.
what I know with working with my practitioners, and we have female practitioners, but most of my women, whether they are bisexual or straight, like working with men. And so most of my women, and a lot of my women are heteronormative, and so they like working with men. So these guys, right? They will come out of a session and they'll be like this, like first, like the woman, of course, she doesn't know what she's doing there, whatever, and I won't, and da, 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 da. And then, of course, the body remembers, and the men are, and these are like erotic men, right? Embodied erotic men. They come out and they're like this, and then they have to. I need water, It's like they don't have the erotic capacity
Yeah.
of women, even women who have rested their vulva on a shelf for a few years.
Yeah.
It comes back and then they're like, and it's always the discussion. If only we had a vulva, because the penis does not have the capacity for pleasure, for resilience, like the vulva has. So you're absolutely right. So be happy that you've got a vulva. So some of these questions are a little bit similar because they follow a trend. So we're asking about bioidentical hormones. Do you recommend vaginal estrogen cream? You might have answered that. And this woman is sharing that she gets random UTIs. And she does have urinary urgency. There are a lot of questions that are circling this area.
Yes. So, garden analogy. No hormones. My garden is not doing well. What does that look like? UTIs, chronic pelvic pain, pain with sex, decreased lubrication, lichen sclerosis, itching, burning, symptoms that constantly feel like a UTI but aren't a UTI. These are all the signs of a poor vulvar health. How do we then get a vulva back to healthy? Hormones, low dose vaginal hormones. I personally love prosterone, intrarosa. It is DHEA converted to estrogen and testosterone. The hard part is that this medication, it has poor insurance coverage. And again, this is just speaking to that wider narrative of women's sexual health is not valued. Like you can get Viagra for dirt.
Women's sexuality is not valued.
No, not at all.
And we're taught not to be able to even trust our own bodies. We need white men up in government to control our bodies because
oh my gosh,
because we can't control our bodies.
Could you imagine? Could you imagine that we have agency over our own bodies? Yeah, no, it's crazy, but yeah. So I'm a big believer in vaginal DHEA.
Can you slow that down? What do you mean by that? Vaginal what?
DHEA. So it's a type of it's a precursor to testosterone that is then broken down in the body. When you insert the tablet into the vagina, it is then broken down into estrogen and testosterone. So that gives you, to me, it gives you everything that you need. And there's so many there's been several studies. Currently, it's FDA approved for pain with painful sex, but there's actually recent studies. We have 2 studies coming out, and then a study that also shows that DHEA is actually even better for UTIs than vaginal estrogen alone. But if you are in a pinch, If you need something, you need just something on this garden, right? Something is better than nothing. Let's say that you're not able to afford vaginal DHEA because it has really poor insurance coverage. Start with vaginal estrogen, because again, it's part of that equation. You need estrogen and you need testosterone. Anything is better than nothing. Estrogen has several effects. It prevents your labia from getting smaller and resorbing or disappearing. It helps to keep the tissue supple. It helps to promote blood flow to the tissue. So it is part of the equation. So every single person should be advocating in the doctor's office when they are reaching perimenopause age for being on low-dose vaginal hormones for at least the rest of your life. Because you would never stop watering your garden, right? Never stop watering your garden. Low-dose vaginal hormones are also really safe. That's the other question that people always have is, oh my gosh, what about the breast cancer risk? What about this, that, and the other? There have been so many studies to debunk the idea that low-dose vaginal hormones can cause breast cancer. We actually give it to patients that are actually actively being treated for breast cancer, because a lot of the treatments for breast cancer strip you of your hormones, which then causes a lot of vaginal and urinary symptoms. So you get your mammogram, you get your colonoscopy, and you get your tube of vaginal hormones. That should be your year 40 visit. That should be what's happening. But unfortunately, many doctors aren't having these conversations with patients. And so by the time that the symptoms start coming, they're still not having these conversations with them. But if you start having these conversations and you do not let your doctor gaslight you and tell you, oh, it's dangerous, oh, it's this, you're going to be your own biggest healthcare advocate in the healthcare system. So anything is better than nothing. My personal preference is vaginal DHEA. But if you're only able to get vaginal estrogen from your doctor or your insurance company, that's better than nothing. And for many people, that's enough. Because actually, fun fact is that your estrogen completely goes to zero when you're menopausal, but your testosterone, you still have low levels of testosterone because it's also made in several parts of your bodies outside of your ovaries. So in some people, that's enough. So let's say that you get started on vaginal estrogen and you're doing great. Done. Say less. You're good. But that's not everyone. And so some people, even on vaginal estrogen, they're still having symptoms. That's when you start really pushing and advocating for a vaginal DHEA.
I've got a question for you that I think
Please.
people will maybe relate to or not. So lots of women are taking weight loss drugs. I am.
Mm-hmm.
I'm on an advanced form of semaglutide.
Yeah.
And I've lost very slowly over 2 years, 40 pounds, which I
Amazing.
needed to do for my cardiac health.
Yeah.
And what I was told, and I don't know if this is an urban legend, was that estrogen is stored in fat. Is that true? And if that is true, are we going to see women who have been carrying menopause weight or premenopause weight? They're dropping their 40 pounds, the 20 pounds, the 60 pounds that they may have been carrying or more. And now, out of the blue, they're starting to have, like I am, a little bit of discomfort in their introitus. They've never had that before. Is there a relationship to what's happening in the weight loss community and estrogen and vaginal pain?
I love that question because it's complex. And also the sexual medicine research team, we're currently doing some projects around this. So in theory, yes, there is a specific enzyme called aromatase, which converts testosterone to estrogen. And so we particularly speak about it in the male population. So when men are getting evaluated for infertility, if a man is overweight, they have higher levels of estrogen. So they're converting the testosterone to estrogen. The thing with menopause, perimenopause is that your testosterone levels are already lower. And so are we seeing higher levels of estrogen in overweight people in perimenopause, menopause? I haven't seen that data yet, but it is, if we're kind of thinking along that same line, it could potentially be there. And also, I think it's just one of those things that we just don't have enough data yet, but there's already an option for treatment for that, which is low-dose vaginal hormones. And so, but from a research standpoint, I'm very curious, right? I am very curious, because are they going to have higher, more severe symptoms as they go through perimenopause and they're also losing weight? Are we going to see a higher incidence of UTIs and more severe UTI symptoms? We don't know. And also, the cure is already out there. So we may not even have to find out ever, if people just had started having these conversations with their doctors about getting started on low-dose vaginal hormones.
So a lot of women here are, some of the questions are about, the shitty healthcare system that they're in, and they can't even get appointments with their doctors.
Yeah.
And we're not over yet, but I want to start to put this in. So what I tell women when they say, is Back to Body coming to Minnesota? And I'm like, no, actually, we're not coming to Minnesota. You actually have to come to us wherever we are. Is it unusual for women who need this treatment to actually travel to you to be seen? How do women there's a woman says, I live in Austin, I live here, I live there. How do I get to work with you, Dr. Madsen?
Yeah. So that's a fantastic question, Sam. That's a very challenging thing, for many people. I've sat with so many people and heard just their stories and their barriers to getting care. On top of my personal practice, I'm also creating several tech industry, like tech for me is like companies like Alloy, MIDI Health, Maven Clinic, all of these kind of like menopause femtech companies have been really helpful, because no matter what, it's really hard for me to see every patient, right? There's just so little doctors for so many women and they're suffering. I love working with people. I spend a lot of time. I love the science. I love making sure that you understand your body. I like getting you to your goals. I also incorporate pleasure through Pamela's, I learned all of these things about sexual wellness all throughout. And so I do have a telehealth company where I have several offerings where if you're in the state of California, I can work one-on-one with you, and actually prescribe medications, optimize your menopause care, your menopause health, get you, I think so many people are so scared of menopause, and I actually think you actually spend, not think, I know, you spend way more time in menopause than you do in your reproductive years. And so why is it that we don't celebrate this part of life? Like, I think it is like leveling up, right, in this really beautiful way. And so I take that approach and like, yay, we're going through menopause, how exciting, and let's get you to a place where you're super happy and comfortable. I also have a one-on-one consulting for just medical advice. And I say this because so many women don't know even where to start. So if you're someone that's out of state, that person that's from Austin, I'm happy to work with you on hearing your history. What is the and then talking about through like, okay, what's the best way to get you to where you need to go? Coaching you even through how to talk to your doctor. So many women I worked with when I was a clinical professor at UCSD, and then I left to go build this tech company. So many women just would get gaslit, would get told the wrong information. They didn't know how to talk to their doctor. They wouldn't know what to ask for, what to advocate for. That is a great service for anyone that's out of town, out of the state of California, because I'm only allowed to prescribe in the state of California.
Links, guys, we're going to post all the links at the end. So stay
Yeah.
with us and you'll get all the contact information. And so, but if I live in New York, if I wanted to see you and be prescribed, I would take a trip to California.
Yeah. Yep. Yeah. Come see me. Come over and see me.
But fly to see me to do a workshop or a retreat. You get on the plane, you prioritize your body, and you take a trip. Right?
Yeah. Yeah.
Is that crazy?
Yes.
I don't think it's crazy.
Yeah.
So
But
another question here is, initially, do we take our vulva to a gynecologist or a urologist?
okay, so I'm one of 7 urologists in the world that also does Vulvar Health. So you're going to have to go to a gynecologist. Urologists don't know how to do this, unfortunately, and neither gynecologists do. So that's the maddening thing that I have to sit with of the doctors that you're supposed to go to don't actually value this. There are some amazing gynecologists out there that are doing this work. Dr. Sarah Signa at GW just opened the first vulvar and sexual health fellowship. Y'all, that's the first in the country
Wow.
in 2024.
Wow.
That's where we're at. And I also love teaching women about also this is like I kind of want people to get a little upset about like this is what we have for you is really minimal thing. So you should be going to a gynecologist for your vulvar health, but unfortunately many of them aren't. Being one of 7 that of the urologists that have this, if you have ever heard any of us talk, Rachel Rubin, Ashley Winter, Kelly Casperson, we are all trying to teach other urologists how to do this work. We're all, the AUA is this year right now, and we're all teaching a course on women's sexuality to teach these doctors about it. The AUA is actually becoming way more supportive of women than I would say ACOG. I said it, it's out there. But on average, the average urologist isn't going to know how to do this. And unfortunately, the standard gynecologist, because it's just not in their training, won't know how to do this as well. And this is just the state of our healthcare system right now. And that's what I'm trying to fix.
Yeah, which is not fantastic. But look, but we're,
No.
we're pushing that needle up a hill. So this beautiful woman is saying, look, I'm 72 and I'm in a relationship with a 44-year-old. I love the gap. It's a good gap. But she's saying that the garden is dead. Her clitoris isn't responding. Where are all those thousands of nerves? I'm frustrated. I'm on a hormone suppository 3 times a week. I've tried Scream Cream. I don't even know what that is. Prescribed by my doctor. I never went on replacement hormones after menopause because my mother went on HR and developed breast cancer. My hair is falling out. Help. I'm in California. She would love to get to see you, Dr. Urella. Are you able to answer this in kind of a bigger, more general way for women who feel like their clitoris isn't responding?
Yeah. And I think this is where you can speak to where you come into play.
Oh,
Yes. So so there are many things that change in the body. Like I could talk to you of all about the science and the nerdy stuff, right? Your clitoris needs testosterone, period. Testosterone is what causes the clitoris to grow. It's what keeps the clitoris healthy. The clitoris and the penis are the exact same structure, being the exact same things. This is why, again, I say I am a big believer in science and not just like women do estrogen and men do testosterone. Like if you actually look at the science, it's very different from that. And also, I could give you the most perfect clitoris. It's the healthiest clitoris ever. But if we are not in tune with our body and our clitoris and the way that our body responds to all these things, it also makes it hard. So I think this is where, Pamela, you can start talking about, the work that you do and like how you helped one of my patients who we had made her vulva perfect. It was perfect, and yet she still couldn't get to pleasure and fun and doing all, and she did all the right things and yet still
right.
couldn't get there.
Well, I think a big part of all this, right? So there's the medical piece, and then there's, things that are not going right in our bodies, right? And where we need support and where we can do preventive health and have healthy vulvas. Absolutely. And there is something about reactivating our desire that we can't quantify, right? We can't quantify what that is. To get women from being frustrated and bored to nervous and excited about the possibility. And when we do that, we actually start to move arousal in their bodies. So they're not moving arousal in their body. They're not moving all those beautiful natural inner pharmacy chemicals that come along with sexual excitement and turn on and even fear, right? So sometimes when women walk in to a retreat or a portal, they're really, really nervous, but they notice actually that they're feeling their vulvas and they're feeling their vulvas for the first time because they're feeling arousal. And so, yes, this is a part of the equation. A part of the equation is actually working with guided people. You have fear in your body. It's hard to do it with your partner. And your partner may be frightened of hurting you. So your partner may not be giving you the kind of sexual energy that you need because they're frightened of hurting you, right? And like, I want to be like, I have this idea that I want to be taken. Okay, but when your partner takes you, their experience is that they're hurting you. And so they're not necessarily bringing you that energy. And so you're not becoming awake erotically. So sometimes when you work with a professional, like at Back to the Body, you're able to leave all your relationship stuff aside and have a practitioner who understands and who can work with you and who can reawaken that flame inside of you. Because yes, you need all these wonderful hormones, but you also need the flame reawakened. And for so many women, they don't know how to do that. And that's a big part of what we do at Back to the Body. And yes, that's a beautiful article that she's posting that you wrote. What was your experience when you came to our portal and you saw the women and you saw the live demo? How did you feel how did it open your eyes maybe? How did you feel about that?
I loved it. So there is only so much in my toolbox that I can do as a surgeon and as a scientist, and someone that cares a lot, right? And so I know my limitations. I can only get you so far. And watching the portal and going to the portal and really experiencing that it was just like, oh my God, this is what I need for the patient, that like I fixed everything and they're still not there. They're still not tapping in. They're still not reaching their goal of pleasure or their sexual wellness goal. Like we stop their UTIs. They're lubricated. They're not having pain anymore, but they're not getting to pleasure. Being able to watch that experience and see how I as a doctor can be an even better doctor by knowing what's outside of the realm of science, what's outside of the realm of pharmacology and all these things of like, oh, a lot of it is still in the body, like back to the body.
Right. You have it in a pharmacy.
Yeah. And so it's been great. And I've referred, and I mean, just the patients that I've had work with this modality and sexological body work, has just been so night and day in their course. And, taking a really pleasure focused approach has actually changed my clinical practice of I now incorporate pleasure in our evaluation. And now I have resources in my toolbox to make sure that they get there. And so I loved it. Especially in the realm of orgasm's a really tough one to do. We're very limited on what we can do clinically. I can make sure all your organs are healthy. I think about it all like running a race. You need tennis, you need shoes, you need a shirt, you need like some pants. I can make sure you have all those things, but I can't actually teach you how to run. I can't actually teach you the stamina. I can't teach you the mental thing. Sex is not just biology, it's mental health, it's spiritual health, it's emotional well-being. If those things aren't all aligned, it's going to be really hard to get to your goal. And I think this practice plus my science gets you all aligned.
Absolutely. Women have got really, it's like, how do you get back to your body? You bring your body, right? So you bring you avail yourself of all the tools that are out there. And we have a portal coming up in Colorado in June, and we have an early bird, and it's not time for the links, but we'll just pop that up since we're talking about it. Thank you for being generous and bringing it up. And we have a few more questions, and we're going to put up all the links at the end and some special offers. You don't want to miss the special offers, so hang into the end, okay? Why don't we just take a few more? I think you've answered the questions around HRT, but pills, pellets, topicals, what's the best?
Yes, so we're going to go strictly by guidelines. We typically recommend against pellets. Again, because it's just such high doses of hormones all at one time. So there's that much safer, much more effective, and much cheaper options, depending on, and this is again, policy change needs to happen so that these quality of life medications and life-saving medications are more affordable. But there's let's go by estrogen. Estrogen, I'm strongly a big believer that the pill is the worst form of estrogen. It has the highest risk of blood clots, highest risk of sexual dysfunction, and it also has the highest risk of cardiac dysfunction. And they're much safer options. Transdermal, so anything that's absorbed through the skin, that can be a patch, that could be a cream, that could be a gel. Also, it could be a vaginal insert. There are several vaginal inserts, so one that's monthly, one that's every 3 months. So those are much more safer options than the pill. I never prescribed the pill. I can think about it 2 times when I prescribed it, and it was really out of reluctance. And shared decision making. And then progesterone. Progesterone, the best way to take it is orally. Progesterone taken through the skin is not, it's not well absorbed, and we need progesterone. Anytime we have estrogen, we need progesterone because it helps to protect our uterus from cancer. There's actually been studies showing that people on dual therapy of estrogen and progesterone together actually decrease their chances of uterine cancer. So it's good for the uterus, but you always need estrogen and progesterone in the setting of a uterus.
Nobody's telling us this.
I know. This is why I'm trying, y'all. I literally left my clinical practice because I see that these are huge problems in the world that I really want to solve because people are dying. These are all preventable things. You can also, if some people don't do well with estrogen orally, so they can actually put it in the vagina to get this. It's all about concentration. It's because it's a bigger concentration. You can put it in the vagina. You get it that way. And then in terms of testosterone, transdermal, again, and the reason for that, so anything absorbed through the skin, is because there's just not testosterone formulations for women. So we have to take what is the male dose and then cut it in like the 10th of the dose. The best way to do that is with something that's like a gel or a cream that you just put on the skin. Again, a pellet, because they're not even pellets for women, it's just such high doses all at one time and can cause all of these other side effects that people may not want. For many people, they just want to get back to their normal. And so those are the best ways to safely go back to your normal. And the other question that people always ask me is, what's normal? And I'm like, what's normal? That's a question that you have to ask yourself.
Right.
We celebrate our diversity in every single person, and I want us to celebrate our diversity in hormone regimen. My hormone regimen versus your hormone regimen may be vastly different. It's just what works best for your body. And this is why I really stress to my menopausal patients to get in touch with your body. One of the things I always see is the loss of self. Loss of sense of self in my patients when they come to see me. And I love empowering women to be like, no, let's get back to you. Let's figure out who you are. And it's a lot of self-inquiry, touching base. What do I like? What don't I like? What feels normal? What doesn't feel normal? And then we get to that. So this is a big time of transition. And I think of it as this beautiful time of transition where you get to really get in touch with yourself, really get to love yourself, really get to treat yourself to your own health. And yeah, I love being able to foster that and work with people to do that.
What I'm going to do is I'm going to hit a pause button for a minute. I want to answer everybody's questions, and we're going long. And and don't worry, we're going to answer your questions. You took the time, you got here, we'll do it. But I want to take a break right here. And I want you to tell us what you're doing and how people can get in touch with you and what your projects are. And Christy's going to pop up those links, how they find you on Instagram, how all the things. So tell us about them, and Christy will pop up the links.
Yeah, so I was a clinical professor at UCSD. I opened one of the first Vulvar Health clinics in the United States that took insurance. It was very widely successful, but unfortunately, seeing all those patients made me really realize like there are huge systematic issues to this problem. There's just not enough doctors for the sheer amount of women and people that will be experiencing menopause. So I left that position and created a healthcare startup called Vulva AI. So this is essentially being your own. I wanted to, the story that I heard over 2,000 times was doctors don't know, patients don't know, and patients don't have resources to find out. And so I wanted to fix the last two because I can't make every doctor. I spent 2 years on the lecture circuit, burning myself out, trying to teach doctors because I was like, I learned, now I want to share it. I always want to just share good like evidence-based education.
I understand.
And yeah, but there were only a couple doctors that really wanted to care and learn and do this. And I was like, I need every doctor to learn how to do this. And I kept seeing this huge problem of doctors refuse to learn, and the only people that are suffering are patients. So I decided to create Vulva AI, which is a healthcare platform utilizing artificial intelligence and technology so that you can become your own vulvar specialist. All the things I know, you know, like you can also learn about your body, learn about all the things that it can be doing, like essentially take what I do in clinic and deliver it into an app so that when you go to the doctor, you know how to advocate for yourself. You have all the best evidence-based resources. You know exactly what tests to be asking for. You understand your body. You understand the science behind your body. You understand the science behind your vulva. And so that's what I'm building out now. I've been in the UCLA Health Accelerator. I'm doing an LA Accelerator, and we're opening a fundraising round now.
Oh.
The thing is, all of this needs funding, all of this needs work, and venture capital doesn't enjoy women. So this is what I'm working on and raising and building. When I say this is a love letter to my patients, I am literally trying to solve the problem of how are there not enough doctors for this many women? And I believe that tech is the best way to do this because currently the governing bodies, ACOG, like AMA, who's training medical students, who's training gynecologists, who's training all of doctors, they're not caring about this. This is not their number one issue. This is like their number 40 issue. Actually, it's not even on their list. I testified in front of the NIH about these issues. And, you know, it's like sexual health is just at the very bottom of their of their care. And unfortunately, sexual health also includes menopause care. And so, you know, we're not being taught, doctors aren't being trained on menopause. That's the T. Like, and I need every patient to know that, and I need them to arm themselves with education to be able to protect themselves through the system. And on top of that, I'm also have my own telehealth company where I give and where I treat patients and also give medical advice. In a perfect world, I would be still at a clinic and doing all the things, but I saw such huge problems. And with great power comes great responsibility, right? My ability to take care of all genders, my ability to do research, my ability to kind of say fuck the system and like speak truth to power has made it so that I am in these spaces, and I do want to change how people access healthcare. So that's what I'm doing. I love working with people. I love support. I'm just a very mission-driven person. I'm a huge patient advocate. And also, I need everyone to know that I am one person. I cannot change the system. It's going to take all of us. It's going to take a collective roar of women to say, hey, I am not forgotten. I am here, I am thriving, and I deserve better. I want every woman to know I deserve better. Because that's what's happening on the men's side of things. Let me tell you, as someone, my men's health clinic, not one time do I have men saying, no one believed me. No one gave me the medication that I need, the life-saving medications that I need. And yet in my women's health clinic, that's all the conversations were. I was having to coach them on how to talk to their doctor, how to be believed. And I was like, this is nuts. This is unfair.
Because we have so much shame. We have been so indoctrinated about the
Yes.
shame of our vulva, the smell, the taste, the look. We don't even know what vulvas look like. We don't know what our sisters' vulvas look like. We don't know what is normal, what is a normal vulva. Normal vulva is your vulva. But we also have
Yes.
we
Yes.
also, we're very internal. We're not like the guys at the gym where everything is hanging out there. We have a secret garden and we actually have to
Yeah.
go in. And so there is a lot of sexual shame. And
Yeah.
and that goes across the board from our medical issues to our sexual wellness erotic issues. And
Yes.
so what we're seeing now is it's so ironic, right? Like we're finally seeing a small shift towards women's healthcare. Back to the Body was just featured in CNN Travel and in Condé Nast. 13 years ago, that would not have happened, Dr. Maria. Would not
Yeah.
have, okay? Women showing their faces. All this now happening, your work, all this happening under a cloud of reproductive constriction, whether it's fertility or choice, it's all the same. It's just it's like all happening together and it's crazy making.
Yeah.
And women need to vote, women need to speak, women need to be advocates, and
Yes.
women need to share information with other women. How did I learn about you? Through another woman. How
Yeah.
did you learn about me? Through
Or
a
another
woman
woman.
being brave enough to share about the erotic work, the erotic work, the sexual wellness work that they were doing with Back to the Body. So it takes some courage and fierceness, but there is a thriving sisterhood of
Yes.
women who are sharing information, sharing resources, and are finding that they can live to their full capacity. And I loved what you said, that it's a combination of things.
Yeah.
And, would I fly to California to see you? Yes. Will I be flying to California to see you? Yes. I love your I love all about the AI, vulva AI.
Mm-hmm.
I love that. How amazing would that be as a resource for women literally around the world? And so
Yeah.
I'm going to make an invitation and then we'll answer those last couple of questions. And I think it's time to stop.
Yeah.
And I have to tell you that this has been one of the most vibrant, exciting, and important webinars I think I've ever done. And so thank you, first of all. Thank you. So for those of you who are interested in Back to the Body, we've mentioned we do this wonderful 3-day weekend. So Friday, Saturday, and Sunday, it's non-residential. You are held in a beautiful container, and you are not going to be expected. You're not going to have sexological body work in a traditional way, but you can see what's possible. You will leave the weekend with tools and workshops. And we're having a special offer right now for a little VIP group, our first 10 women who sign up for our portal in Colorado, where they get to have a little VIP cocktail with me and Cosmo Means and Christy and Kasha to answer some of their more personal questions. And I believe that we have one spot left in our retreat, a full retreat in Colorado, and I'm sure Christy will put a link up for consultations. And if you have questions about whether this is right for you, you can speak to Christy and see if this is right for you. I want to answer one or two more of these, and then it's time to go. And this one's a little different, so I'm going to pull it out. Okay. It's a younger woman in her 20s and 30s.
Love
And
it.
she was premenopausal. Like this, she's premenopausal and she has repeat UTIs. And the vulvar dysfunction that you're speaking of, she asks, is vaginal estrogen DHEA useful for treating premenopausal women as it is for post? I think it's such an important question. Thank you for
Yes.
asking it.
Yes. These are my favorite girlies as well. It's same equation. Estrogen and testosterone. Your vulva needs both. So there are many medications, many disease states that actually change your hormones outside of, not that menopause is a disease, it's a natural progression of life. So menopause is not a disease state, it's a natural progression of life, but there actually are disease states and also treatments or medications that can change up your hormones. The most common is birth control. Oh my God. Well, it's like the easiest visit I have ever is like that. This is why I love these patients, because it's like a slam dunk. Pain with sex or UTIs after sex. Also, everyone, you should not be getting UTIs after sex. That should not happen. That's been like my biggest thing I like that my research has shown. You should like we're doing a disservice and just being like, yeah, all women should have UTIs after sex. That's a normal thing. It's not normal. And it's actually preventable. And it's oftentimes a symptom of poor vulvar health. But yes, so my favorite, well, some of my like most straightforward patients, my premenopausal pain with sex and my premenopausal UTIs, especially my UTIs after sex, like, and they're classically healthy, all the things, but they took birth control. Even if you took a pack of birth control, even if you took 10 years of birth control changes your testosterone, period. Oral birth control changes how your body uses testosterone, which then means that your body doesn't have any testosterone. And this is where the tricky thing is, if you look at the standard labs, many people still look like they have normal testosterone, but there's a special lab that you have to order. And if you order that lab, you see that most people's testosterones are low after they take in birth control. And then you give them some vaginal DHEA or topical estrogen and testosterone, and it fixes their symptoms. Other things that can cause this are, acne medications. Many acne medications are anti-testosterone medications, spironolactone. Conditions like hypothyroidism, vitamin D deficiency can cause low testosterone. What other things? Breast cancer treatment, endometriosis treatment. So there's so many medications, so many disease states that can actually affect your testosterone. And because most doctors are not taught about testosterone, I actually was just emergently had an appointment on Sunday. I had like opened up my urgent slots for a good family friend who was a gynecology resident herself, was kept all of a sudden having UTIs and pain with sex, and was just so at her wit's end. She's a gynecologist herself. So the visit actually went from a treatment conversation to also a lecture, because I was like, not only am I going to tell you what's wrong with you, I'm going to teach you why it's wrong, so that now as a gynecologist, you can go back and teach your department. Because that's ridiculous. It's ridiculous that you as a gynecologist don't even know how to treat your own body. And she was like, I know, I feel crazy. And I was like, girl, this is what I'm trying to fix. This is the huge systematic issues that I'm trying to fix. Like, she didn't even know where to find resources and how to fix herself and how to treat herself. This is what you're up against, y'all. Like, this is so tough. And this is why I left my work to go build Vulva AI, but I still love seeing patients, and I'm still able to see patients. And this is a superpower where most people have been told that they're unfixable, they're broken, they're this, that, and the other, they'll never get better. I'm like, that's like takes like 2 seconds. Like it's a whole, I love this work, and I love doing this work, and I love teaching people about their bodies so that they can feel empowered and also feel like they're not crazy. That's the thing, is like, there is something actually wrong with you and we can fix it.
Thank you. I'm going to do 2 more and then we got to stop because
Yes.
have been going for a very long time.
Yeah.
So there's a
Yeah,
question that MUMD, your stuff, the Essential Menopause Package, 20% discount. Can I schedule this in person?
Oh, so right now everything I'm doing is telehealth. Like the initial consultation is telehealth. We can potentially do this in person, depending on just where we're at in our life. But as of right now, just because starting a health tech company and also maintaining a clinical practice is 3 full-time jobs.
I get it. And the last question I'm going to take, because we haven't answered this one yet. So someone is talking about that it's many years since menopause and they still get night sweats.
Mm-hmm.
What can they do about that?
Yeah, so this is where these tricky situations come into play of in a perfect world, if you were seeing a menopause specialist that felt comfortable with, giving tailored menopause care, they would not have taken you off of your hormones. You would have been continued because you're still symptomatic. This is that tricky situation that comes into play of you've stopped your hormones and is it safe to restart? There's just not a lot of great data around the safety of this. And this is where I just have really frank conversations with patients of, look, listen, are you miserable? Yes. Is this the safest thing to restart hormones? We don't know. Can we do this in the safest way possible? 100%. What do you feel comfortable with? I think many doctors that don't work in menopause and don't know how to, do this work would just tell you flat out, no, there's nothing you can do. You can start an antidepressant. Venlafaxine is the antidepressant that's used for hot flashes. Then there's also a new FDA-approved medication for hot flashes that also have side effects as well. It is probably super expensive. And so it's just a tough situation. And those are the ones, it's a more nuanced conversation with your healthcare provider. You just have to have a healthcare provider that gets this, that understands, and is very quality of life driven while also trying to maintain your safety.
Thank you so much. I know I promised I was going to get to everyone. We've never had so many questions and such an active group. Maybe you'll come back again and do this with us
Yeah.
another time, because people want to know about GSM and struggling with chronic burning. And I don't know if we hit on that. Did we hit on that? Was that
We
in
did.
the conversation?
GSM is just that's what happens when you have no hormones. It's a symptom of poor vulvar health.
Got it. So everybody, let's give a round of applause virtually to Dr. Maria Uloko, who is really a standard bearer in this field, and how fortunate we are to have this and to have this recorded and to share this with the women who weren't able to be here live. And Rosie says clapping. That's wonderful. And you're going to get a follow-up email. You will get a follow-up email with all the information, all the links, all the everything. And you know what? Do it. Do it. Do all the things. Because it's only by removing the obstacle, which is usually us, right? We have all the reasons why this won't work for us. All the things, right? Move your obstacles. When you move your obstacles, you get to have a full, vibrant, extraordinary life, which doesn't end until we take our last breath.
Yes.
And we should be present, alive, healthy, and living in our garden.
Yeah.
Until that last breath. So thank you, Dr. Maria Uloko. I have loved getting to know you. You're an extraordinary human being. And I think you've helped many people today, and all the others that are going to get to see this replay.
Oh, thank you so much for having me. I love partnering with you. Thank you for enhancing my practice in the work that you do and teaching me of not only getting into the weeds of the science, but also incorporating pleasure. It just makes me a better doctor, much more fun.
You're so much fun.
Yeah, I love it. I love it. And thank you all so much for coming and hearing me talk nonstop about the system, fighting the system, and empowering yourself. But I really do believe it. We live a long time on this earth. This is a gift. And it should not be the ignorance of the healthcare system, the dismissal of women in the healthcare system that makes you suffer. And I wish in a perfect world that the healthcare system took accountability and actually did what it's supposed to do, like it is for men. And I will continue to call them out on it always and never stop talking about it. But I do need my voice is helped with other people's voices,
Absolutely.
all shouting, all screaming, all demanding that they get the quality of life that they deserve. Because it's not just quality of life, it's actually health. It is your health that is associated with this. You know, people die from UTIs, people die and have significant quality of life issues with chronic pelvic pain and all these things. And it's like, why are we suffering when this could all be preventable?
Absolutely. So everybody, watch for your email, get the links, do the things, because it's great to hear about it. It's great to get the endorsements. It's great to find out the information. But if you don't do anything with it, you're right where you were yesterday. So let's do something with it. Thank you. Have a
Thank
great
you
night.
all.
Be well. And we'll be
Bye.
trading glass tips later. Okay.
Yes, 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 yes.
All right.
Bye.
Bye-bye, everyone.